In healing, a doctor calls for an overhaul of the mental health care system. This is printed in npr.org. It was published March 1st, 2022. U.S. mental health care needs an overhaul, argues former National Institute of Mental Health Director Tom Insel. For over a decade, psychiatrist and neuroscientist Dr. Thomas Insel headed the National Institute of Mental Health and directed billions of dollars into research on neuroscience and the genetic underpinnings of mental illnesses. Our efforts were largely to say, how can we understand mental disorders as brain disorders, and how can we develop better tools for diagnosis and treatment? Insel said in an interview with NPR. But in the very first pages of his new book, Healing, Our Path from Mental Illness to Mental Health, he admits that the results of that research have largely failed to help Americans struggling with mental illnesses. Our science was looking for causes, while the effects of these disorders were playing out with more death and disability, incarceration and homelessness, and increasing frustration and despair for both patients and families, writes Insel. But Insel's book is less about the failure of science in helping people and more a critique of almost every aspect of the mental health system. NPR sat down with Insel to talk about how he came to realize where America had failed and his journey to find the answers to addressing the country's mental health crisis. What were some of the scientific discoveries and developments you oversaw during your time at NIMH? We did several large clinical trials for depression, for schizophrenia, for bipolar disorder. The bottom line for most of those was that in the real world of care, medical treatments were not as good as we thought. And I think that there was an important insight that really charged us to say that we've got to do better in terms of developing more effective medications. At the same time, I think we had a greater awareness, particularly in the later years of my tenure, that we could begin to combine treatments in a way that was very effective. And where we saw this the most was how we began to address the first episode of psychosis for young people with a disorder like schizophrenia or with the form of bipolar disorder. What we began to understand is that by combining medication and psychological and cognitive therapies, bringing in families and giving agency to the young person involved, providing academic and employment support, we could actually help kids recover, and that we could get to a point where kids who had had a first episode of psychosis weren't destined to have a second episode. That sounds significant, but did these discoveries translate into better overall mental health of Americans? Well, one of the things that I've struggled with was trying to understand this gap between our scientific progress and our public health failure. I think we've got to understand why it is that we've been able to do so well on the science front and so poorly on the delivery of care for the 14.2 million people with serious mental illness in this country. Tell me about the time that you were forced to confront this paradox. So when you're the NIMH Institute Director, you have to spend some time talking to the public, meeting with family members, or meeting with patient groups. I was doing that at a talk I was giving to a large group of family members in 2015, and I was showing them the spectacular success we had had with stem cell studies of neurons in schizophrenia. What we were able to do for mapping specific genetic variants for autism, and how we created great models on the epigenetics of stress and depression. And somebody got up at the back of the room and said, I have a 23-year-old son with schizophrenia, and he's been hospitalized 5 times, and he's been in jail 3 times. He made 2 suicide attempts. Look, man, our house is on fire, and you're talking about the chemistry of the paint. I was initially quite defensive, but there was a part of me that realized that the pain that he and so many people were feeling had an urgency to it that our science wasn't addressing. And that ultimately is why I left the National Institute of Mental Health, initially going to Silicon Valley and working in the tech industry, and later getting more involved with trying to start what was essentially a social movement to bring attention to the fact that this house is on fire and that this is a crisis of care. This is our failure to be able to provide the things that we already have in hand. What are some of the things that we know work, and some of which we have managed to provide? So, most of the time when we talk about serious mental illness, that means schizophrenia, bipolar disorder, severe depression, perhaps eating disorders. And most of the time when you talk about treatments, people immediately get into a conversation about medication. Is America over-medicated? Is it under-medicated? But are the medications actually safe and effective? All of that is a conversation we have to have. I think it's important to realize that medication may be a necessary part, but that it's completely insufficient part of the care of somebody with a serious mental illness. There are psychological supports that are critical. There are family interventions that are really effective in some ways, what you see with the medications. And there are extraordinarily important forms of rehabilitative care, like housing support and supportive employment education, things that help people to get a life. Tell me about the importance of people, place, and purpose, and how that's a key to recovery. So I was talking to a psychiatrist who works on Skid Row in Los Angeles, and he said, we really need to be thinking about recovery, not just acute care here, he said. So what is that? What do you mean by recovery? He said, it's the 3 Ps, And I thought to myself, all right, the 3 Ps. You've got Prozac, Paxil, and I guess it could be psychotherapy, because technically that's a P. And he kind of just looked at me, out of the corner of his eye, still shaking his head. And look, it's really simple, man. It's people, it's place, and it's purpose. Those are the 3 Ps. We don't address those 3 Ps in our traditional medical care, but if we want people to recover, if you want to see someone have a life, we have to think about people's support, social support. You're going to make sure that they have a place, a sanctuary, where they have a reasonable environment with reasonable nutrition and a place that they know is home, and they need a purpose. And I just don't see that happening in what you call today's mental health care. It's not that sort of a recovery model. And yet, to me, this is the most important point of all. When I talk to people who have struggled with mental illness, I hear a lot about the stigma and the isolation that follows that. And that social isolation has all kinds of negative long-term impacts on physical and mental health. And is that partly what you're talking about? Well, it is. The many things I think we don't understand about people with serious mental illness is we don't fully appreciate how loneliness is a major part. So many times when someone has been psychotic, they end up burning a lot of bridges, and so they don't have the social capital they might have once had, and that they now need more than ever. So the beauty of programs like Fountain House, a social club for people with mental illness, is that it begins to give them the opportunity to regrow that social capital and recreate connections. The way I've come to think about it more and more is that if you're a runner and you break a leg, you get that acute medical care to get the leg repaired, but it takes you months of hard work to get back to running again. We understand that, and by the way, you even support and pay for it. We call it rehabilitative care, and it's hard and it takes a long time. But if you have a psychotic break and people haven't quite come to terms with the fact that it takes a year or more to fully recover and to get back into the race, the result is that many people don't actually get through the whole process of recovery, and they might not get rehabilitative care. Usually it's not even paid for. And so when you find these clubhouses, for instance, like Fountain House, they exist on philanthropy. They are nonprofits trying to make a go, and that they are for people critical for this recovery process. There's a 3-digit crisis hotline, 988, and that's about to go live, or it already has. So let's understand that 988 is not 911 for mental health. With 911, you have a dispatcher who you call, and they contact a first responder to come help. With 988, the person you call is the first responder. This is telehealth. Something like over 90% of calls will be dealt with by that person who's on the other end of the 988 line. So we have to really get smart about thinking about what the training is like, who those people are, and to really understand that they're not dispatchers. They're truly telehealth professionals who are essentially both the person answering the phone and the ambulance. The second thing about that is vital and overlooked is that 988 is just part of the whole continuum that we need. Yes, we need a place to call, but we also need the mobile response that's tied to this. And for some people, they're going to need a place to go. That means hopefully not jail or a medical surgical emergency room, where we now have this crisis of people being boarded for many days at a time with mental health problems. We need places like crisis stabilization units, opportunities for people to spend maybe 23 hours, maybe 7 days to be able to recover from whatever that acute crisis is. So all 3 of those, the person to call, the people to come, and the place to go, need to be part of the crisis response system going forward as the states begin to implement this. So I must say, I don't think that many states have understood how essential it is to have that continuum.